All right, so for the first leg check presentation, what we're going to go over is the cervical syndrome. And what I wanted to show you real quick is when your patient lays down, there's only two things that is going to happen. Either the legs present balanced or they present unbalanced. And I went ahead and wrote it out up here. As you can see, when you'll read in your manuals, balanced will look like this, obviously. The legs are balanced, the bottoms of the feet and the legs, everything's balanced. Or they're going to be unbalanced, and that can be right short or it can be left short. For the first thing that we're talking about, the cervical syndrome, it doesn't matter which one is short. All that it matters is that one of the legs is short, and then we're going to go through that presentation right now. So how to do the leg check and what that looks like for the cervical syndrome is one of the feet, one of the legs will be short, and what you're going to do is check that the right is short, and then Julie, can you have you turn your head to the left, please? You're going to let that settle in, and then you're going to recheck and see if there's any changes. Good. And it actually evens out, and I'll get to that. And then Julie, can you turn your head to the right? And again, right short. So you can put your head neutral again. So what happened here on actually Julie does have a cervical syndrome presentation, meaning in neutral position, her head is short. When she turned her head to the left, her feet actually evened out, and that is the definition of a cervical syndrome presentation. Is unbalanced, and then Julie, turn your head to the left. Her feet are now balanced completely, and textbook can be when the patient turns their head, the feet can even, or the short leg actually becomes longer. So if the feet even, or her right leg were to become even longer, that would also be a cervical syndrome. And then Julie, you can turn your head back to the right. So when she turned her head to the right, I go here, I can see that her right short again is still short, meaning I'm going to have her turn her head back to the left. So we name the cervical syndrome based on the way that the patient is facing. Julie's facing left, so we call it a left cervical syndrome. When we find out what side the cervical syndrome is, we come up to the opposite side she's facing, and we start the palpation down the lamina pedicle junction line. What you're going to do is palpate for the mastoid, and if you slide inferior to that, you'll kind of go right into the LPJ. And what you're going to do is do a little heavier palpation because you want to get through the musculature. And what you're feeling for as you palpate from C2 down to C7 is you're feeling for a little just pea-sized nodule, and it's not going to be movable. It's the capsular ligament within the facet joints, and as you're palpating down, you'll feel that tender nodule. And part of the cervical syndrome has two parts to it, a subjective part and an objective part. The objective part is the tender nodule that you're feeling, you're palpating. The subjective part is that it is tender. So you ask the patient, Julie, is that tender right there?
Yes.
And she goes, yep. She confirms it. So the objective part and the subjective part confirm that, yes, there is a tender nodule right at the facet joint, or more specifically, the capsular ligament. Julie is facing to the left, so left cervical syndrome. I'm palpating down the right side, LPJ. I felt the pea-sized nodule. And if you wanted to equate, you can turn your head neutral. If you wanted to equate that to a listing, what that means is there is posterior body rotation of the segment above the pea-sized nodule, meaning that the segment right above the pea-sized nodule is actually spinous left. So we could say that the segment above what we're palpating is a PL. And from there, you can turn your head back left. To do the setup, I'm sorry, can I have you scoot up a couple inches and just place your head or your chin 1 inch below the bottom of this, just a little bit more up. half an inch more. There you go. So proper patient setup for a cervical syndrome is that their chin is 1 inch below the bottom of the headpiece. You want to make sure that the selector knob is set to D, dorsal. This is pushed in to engage the cervical piece. And I'm not going to do the adjustment, but I'm going to show you the setup for the cervical syndrome. So what you're going to do at Life University, they teach you to have the patient turn to the side that the cervical syndrome is, so Julie can turn her head to the left. And what you're going to do is we already palpated that tender nodule, and at that segment, you can also count the spinous processes to find out where you're at. So I'm at 2, 3, I'm at C3. All I'm going to do is take a tissue pull down this way, right here. You want to have a fairly snug tissue pull straight down and have a good contact point. Your stabilization hand is going to take a zygomatic arch here, and you're going to traction up and away and use your contact as a fulcrum. The biggest things that you want to concentrate on is that you're not up and pushing down, but you're here tractioning around your fulcrum and keeping this elbow in the right line of drive. You don't want to have it up here, you want to drop it down in the proper line of drive. The line of correction is P to A, L to M, I to S, up the facet joints. You can turn your head neutral. Another thing is you want to make sure you're in a good fencer stance. Control your angle. You don't want to be up here and be pushing down into the table. And when you actually perform the cervical syndrome, Julie, can I have you just keep your mouth closed? I'm going to raise the headpiece. Like that. Good. So what you do is when the table should be properly weighed out. Sorry. Good. It's up. The patient can turn their head to the left. Slide in, take my contact. Good wide fencer stance. Zygomatic arch. Up and away. And then you drop the headpiece to perform the cervical syndrome adjustment.